Here are my disclosures. Treating lupus patients is expensive. Most studies have shown that the greatest component of direct costs are from hospitalizations, but the indirect costs are 2/3 of the total. The indirect costs represent the loss of productivity in our patients. And then there are the intangible costs, the loss of quality of life, and sometimes the loss of career or personal goals in our patients. Here is a study which pointed out the huge increase in costs, a 3- to 5-fold increase when the patient has lupus nephritis. If the patient goes on to dialysis in the United States, the cost is $100,000 per year of dialysis. As we move into an era of more use of biologics, we have to face the fact that the pharmaceutical costs will go up. But the hope and expectation is that that will be balanced with a reduction in hospitalization costs and perhaps in some outpatient costs, such as fewer visits. We do know the predictors of direct costs. Younger age, because the younger patients are more likely to have lupus nephritis, duration of lupus, activity, in particular severe flares, damage, in particular renal insufficiency and coronary artery disease, and just poor general health. Let's take these one at a time and first look at the role of lupus activity. There are two different patterns of clinical activity. Half of our lupus patients have this pattern of chronic activity. On a physician global assessment, one is mild, and so I might be tempted to put up with this if it's not affecting the patient's quality of life, such as perhaps a chronically low platelet count. But I want you to look at the same patient graphed here. Do you notice that her SLE is above 3? And we now know that a SLE of 3 or higher is going to increase this patient's risk of later coronary artery disease. So if we had better, safer therapies, I would want this patient to receive something that would reduce her lupus activity. Now, half of our lupus patients have this pattern, the flare pattern. This patient obviously needs a new treatment that's going to prevent flares. But that new treatment is going to increase costs. So hopefully it's going to be balanced by her needing less medication, such as prednisone, having fewer hospitalizations. Now, we know that prednisone is the problem, but our regulatory agencies and the United States, our insurance payers, know it as well. So in the United States, the insurance payers have told me that the one indication that they want to see for a new biologic for lupus is the steroid-sparing indication, because they know that prednisone-induced complications are a huge part of the hospitalization costs. We know that prednisone is also going to lead to more coronary artery disease for many reasons, but one of the reasons is that even a small change in prednisone of 10 milligrams significantly increases traditional cardiovascular risk factors, and hydroxychloroquine can only partially balance that. We also know from the Toronto group that 15 years after the diagnosis of lupus, 80% of the permanent organ damage is directly or indirectly due to prednisone. You will remember that I redefined high-dose prednisone. It's now any dose above 6 milligrams, because if that patient gets to above 6 milligrams, she has just had a 50% increase in permanent organ damage. And if she has to be treated at higher than 18 milligrams, her risk of permanent organ damage just went up 2.5-fold. So you can understand why we want new biologics to be steroid sparing, but really steroid sparing. I would like to see these absolute values achieved of hopefully less than 7.5 milligrams. We have to be careful in our own practice that we don't commit our patients to chronic oral prednisone if we don't have to. For that patient that has the flare pattern, if her flares are mild to moderate, this clinical trial called FLOAT proved that the great majority can be adequately treated with a small burst of steroids, either a one-time intramuscular steroid injection or a 1-week rapid taper of methylprednisolone. Here you see the quality of life results. Just 1 day after starting treatment, there's improvement, and you see how it is maintained. Triamcinolone was slightly better at some time points, but both are very adequate therapies. What about severe flares? Luckily, lupologists agree on what is a severe flare. Here you see the Selena flare index with the definition on the right of severe flare. The kappa statistic for agreement on this is very high, and most severe flares are going to lead either to a hospitalization or a large increase in steroids, both of which are going to be costly. One of the things that was proven in the phase 3 belimumab trials was a very evident reduction in severe flares. Here you see that there's about a 40% reduction with belimumab versus the standard of care group. Now this is wonderful, and luckily for belimumab, it had a very clean safety profile. So this did not occur at the cost of more serious or opportunistic infections. But you can see how we have to be very careful about that balance. What are the causes of hospitalization? Only about 1/3 will be due to active lupus, namely severe flares. Medical admissions, in other words, SLE complications, are very high, and infections still account for about 14% of hospital admissions for lupus in the United States. Now, we can predict these. So admissions for severe flare are actually predictable by the disease activity level in the previous year and by a prednisone dose of greater than 10 milligrams. Half of the medical admissions are due to coronary artery disease. Again, any new therapy that will reduce some of these surrogates for coronary artery disease is going to be very welcome. Hospitalizations for infection are predicted by active lupus, and again, a prednisone dose above 10 milligrams and immunosuppressive drug use. So again, any new therapy that can get prednisone down and maybe even allow us to taper off the immunosuppressive drug will be welcome as long as the new therapy doesn't increase major or opportunistic infections. Now, I have always hoped that by using safe immunomodulators, we could at least limit prednisone somewhat. And I want to show you the new data on vitamin D. We looked at vitamin D in our longitudinal cohort, and I want you to pay attention just to the middle part of this slide. The reason that I'm showing you this two-slope model is that it turns out it doesn't help to get the vitamin D level above 40. But what you see is when you get to 40, not above, but get to 40, there is a significant reduction in disease activity and also in the urine protein to creatinine ratio. Now, I want to emphasize this is modest, but let's put it in clinical terms. What it means is there will be about a 20% reduction in the odds that the patient will get a SLE score of 5 or above, and a 13% reduction in the odds that she will develop a urine protein to creatinine ratio of 500, the level where we would biopsy based on the EULAR guidelines. Modest, but this is cheap, and it's really very safe. And obviously, I feel the same way about hydroxychloroquine. We're using it primarily now for its preventive role, but it does have benefit on disease activity in terms of cutting down flares and tripling the chance that a patient with lupus nephritis will have a complete response. That patient that has the complete response will hopefully be off of prednisone, and hopefully after 3 years, based on the guidelines, can be off of mycophenolate as well. But Natalie Costa-Doet has drawn all of our attention to this huge problem we have with non-adherence, and that you and I cannot identify the patient who's not adherent unless we use drug levels. I now feel that we should be like neurologists who do drug levels all the time for their anti-epileptics. We need to do this for hydroxychloroquine, we need to do it for vitamin D, we need to do it in terms of mycophenolate with trough levels. What about the costs of renal lupus? The key is going to be early detection, and that's why I'm such a strong proponent of doing a urine protein to creatinine ratio at every visit. Because with the old dipstick, a 1+ could mean 500 milligrams of proteinuria a day. Early detection, early biopsy, early treatment. And for our patients that already have renal disease, of course we want to borrow the knowledge from chronic kidney disease patients in terms of strict control of factors that are going to lead to greater progression. And you do understand, of course, that the nephrologist, based on this study, picked 130 as the cutoff that they wanted. Now, you know that I'm super aggressive. I look at these same data and think, well, why wouldn't we want to target 120? Because in a normal young woman, a normal blood pressure is 120/80. And in chronic kidney disease, they've also determined what are the best regimens. In this step diagram, you do not want your patient to end up being on the top. You want them, I'm sorry, could we go back one? Maybe not. Okay, so you don't want the patient to be at the top. And what that study showed was that the patients who got to the top the quickest were actually those patients on amlodipine. So we don't want to pick that class of medication. The slowest path to the top was with the ACE or ARB group. And we've also learned from the ALMS maintenance trial that the patients who were randomized to mycophenolate have a longer time to renal flare. Now, why is this so important? Because most patients with lupus nephritis have already lost some of their renal reserve, and every single time they flare, they lose a little bit more, speeding their way towards end-stage renal disease. So when we have these beautiful international randomized trials, you and I have to pay attention to the results. What are we going to do to reduce the burden of cardiovascular disease? It is a huge burden. In our cohort, the risk is 2.66-fold increased, almost identical to the hospitalization data of Michael Ward. There are lupus-specific factors, the SLE day of 3 or greater, low C3, and lupus anticoagulant, but also there are all the traditional cardiovascular risk factors in the model as well. So, a new treatment that reduced the SLE day, improved C3, and reduced or eliminated the lupus anticoagulant, well, you and I know, and the regulatory agencies and the insurance companies know, that's going to reduce coronary artery disease. But here is the most important thing. We have to have steroid sparing because prednisone directly increases cardiovascular disease in this model, which adjusted not only for disease activity, but also for every single traditional cardiovascular risk factors. And you see the cutoff of 10, which will increase cardiovascular events 2.5-fold. But if the patient gets to 20, then it's going to go up 5-fold. Do you remember how that number of 10 keeps reappearing in terms of predicting hospitalizations, predicting hospitalizations for infection, now predicting cardiovascular events. So what can you and I do to reduce the cardiovascular burden? Well, of course, I think we do have to be primary care doctors and treat the traditional cardiovascular risk factors to target. I don't think statins are the answer, except for hyperlipidemia, because statins have not reduced cardiovascular progression in an adult trial, in a pediatric trial, or in mice with lupus. There may still be hope for mycophenolate, which has had benefit in a murine lupus model, but also potentially in the transplant world. But the immediate lupus-specific issue here is we have to get rid of our dependence on prednisone. So in conclusion, how can you and I reduce the burden of lupus? Well, ultimately, we'd like to treat lupus activity without prednisone by more universal use of safe immunomodulators and treating the flare pattern, hopefully with just a short burst of steroids. Of course, we need to reduce hospitalizations, which are the major direct cost burden. In lupus, the activity admissions are from severe flares. Biologics may help us with that as long as we don't have any bad trade-off. We're still facing infection as a cause of about 15% of admissions and half of the medical admissions from coronary artery disease. Of course, you understand how those costs escalate very quickly. A catheterization, an angioplasty, a stent, a coronary artery bypass graft, multiple emergency department admissions every time the patient has chest pain. Now, we want to prevent lupus nephritis. Maybe hydroxychloroquine is the way to do that. We want to detect lupus nephritis early, biopsy, treat. But we also have to try to delay or prevent end-stage renal disease by borrowing from our nephrology colleagues. Thank you very much for your attention.